I'd like to introduce the first session of today, and I call here on the floor the two chairs, Dr. Giovanna Zorzi from Carlo Besta Institute of Milan and Professor Bruria Benziv from Sheba Medical Center from Israel.
What's the music for?
The jingle. Yeah, I'll leave you the floor for the presentations.
I like the jingle, that was very nice. So thank you, Massimiliano, and it's a pleasure to have you all here. So we start the first section about the clinical aspects of GNAO1, and I'm very glad to introduce Serena. Serena, she's a child neurologist and a researcher of the University La Sapienza in Rome. She's very expert both on clinical and also basic aspects of the disease. And she will give a talk about genetic disorders affecting G-protein coupled receptor-cAMP signaling, pathophysiology, phenotypic spectrum, and therapeutic implication. So 20 minutes and 5 for the discussion.
Thanks to Dr. Zorzi for the kind introduction. And thanks to the organizer for inviting me to this great meeting, great organization. Yeah. So, I want to introduce the concept of a group of disease, because GNAO1 is not alone. GNAO1 is part of a pathway. Until 10, 15 years ago, when we had a child with movement disorder, we were in the presynaptic side of the story, dopa-responsive dystonia and presynaptic disorders. In the last 10 years, a lot of genes, postsynaptic genes have been discovered, and all belonging to most of them with hyperkinetic movement disorder belonging to the G-protein coupled receptor cyclic AMP pathway. So, this gene belongs to two groups. They can be transduced molecules or component of the G-protein coupled receptor complex, and we have the GNAO1, the GNB1, the GNAL, the GPR88, just one family, and protein controlling the synthesis and hydrolysis of the second messenger cyclic AMP, the ADCY5 gene, the PD8NA, the PDA2A. These genes are ubiquitously expressed, but we have different brain tissue expressed, reported. GNAO1, GNB1, and the PDA2A are highly expressed in cortical areas, but also obviously in basal ganglia and cerebellum, while the highest level of the ADCY5, the PD8NA, and also HPCA are within the striatum and nucleus accumbens. And these genes are all highly expressive in the striatum, and particularly in medium spiny neuron, where they regulate postsynaptic dopaminergic and adenosine signaling. And all these genes strongly modulate neuronal excitability and the transmission of multiple neurotransmitter systems. In the striatum, these genes, as I say, they're very important for the transduction of dopamine and adenosine signaling. They regulate the levels of cyclic AMP, and the cyclic AMP propagates downstream via specific kinases, pKa, and they have an effect also on the transcription and the activity of channels, different channels, GABAergic, AMPA, NMDA, and at the end they regulate the long-term synaptic plasticity, neuronal growth at the level of spiny neuron, but as I say, they are ubiquitously expressed. This is the very complex post-dopaminergic signal transduction cascade. So we can see the regulation of this pathway on multiple types of channels, NMDA, GABA-A, but also the effect on synaptic plasticity and long-term potentiation. GNAO1 encodes for the G-alpha-O protein, which is the most abundant protein, G protein in the brain. We know that it's highly expressed in the cortex, in the hippocampus, and the striatum, and that controls cyclic AMP production. And we don't know if this control is negative or positive for all variants. This is what we are trying to understand. We know that there's a direct effect on GABA release and on multiple channels, sodium channels, calcium channels, and potassium channels. But we know that there is an important role for GNAO1 in neurodevelopment. These are models published in the last 2 years. So the the knockout GNAO1 mice seems to have defects in cerebellar cortex development. The 2015 mice has a defect in the development of motor cortex, and there are, in organoids model, there are defects in cytoskeleton organization, aberrant neurite growth. So we know that this is a neurodevelopmental disorder, and this is demonstrated also by the most recent models. But moving to the clinic, this is a review of cases published up to May 2022. All these genes have the same spectrum of clinical features, which include movement disorder, neurodevelopmental disorder, and epilepsy. There are genes, the GNAL1, the ADCY5, where epilepsy has not been reported, maybe one case in ADCY5. While for GNAO1, GNB1, the phosphodiesterase, there is a broader phenotype which includes epilepsy and neurodevelopmental disorder. The motor phenotype is very distinctive. We have dystonia, baseline dystonia and chorea with triggered paroxysmal dyskinesia, and the typical trigger are fever, sleep, but we'll see that there are many other triggers. And for some of these genes, there is a frequent evolution into status dystonicus. So we review the clinical features of all these genes. And from a movement disorder standpoint, there is this dystonia and chorea with prominent cranial involvement, orofacial dyskinesia that can be also paroxysmal. All these patients have axial hypotonia. There is an impairment or axial hypotonia and impairment of postural development with difficult achievement of track control and standing and obviously walking. But what I would like to underline is that this is an hyperkinetic movement disorder, but this is also an hypokinetic movement disorder. This is a mixed movement disorder. Outside of the spells and the hyperkinetic episodes, they have an hypokinetic and bradykinetic background with profound hypotonia. And there is a marked susceptibility to a variety of triggers, which, as I said, fever, sleep cycle, emotion, sudden movements, and, for example, menstruation for girls. There are a lot of triggers. The epilepsy. The epilepsy phenotype is not so recognizable, but in the infantile onset epilepsy, typically we have tonic seizures in this group of disorder, infantile spasm. There are patients with febrile status epilepticus, but there are also childhood onset forms of epilepsy, milder forms, generally well controlled, focal motor seizures or partial seizures with reduced awareness. These are the most frequent. And global developmental delay eventually evolved into intellectual disability with prominent language impairment is present in, I would say, 70–80% of patients. I wanted to highlight a few features that I think are very typical of this condition. This is the first family with the ADCY5 deficiency reported, the Ruskin family. And the first article talked about this very typical facial myokymia. And in all these genes, the phenomenology is very different, but the localization is the same. So the orolingual dyskinesia, paroxysmal and non-paroxysmal, are typical of this group of disorders. This is a GNAO1 patient. And here a PDA2A patient, again, dyskinetic spells with all these orofacial movements. That sometimes made me think to the dyskinesia seen in limbic encephalitis, actually. So where the NMDA receptor is involved, we know that the glutamatergic the pathway is involved here. So I don't know, but something to think about. This is a very mild patient described a few years ago. And it's very interesting to see that the phenotype is much milder, but again, there is a prominent orofacial cranial involvement with dysphonia, tongue tremor, and the other feature that we know in this condition. And we have seen a patient that we follow up in clinic. This patient underwent epilepsy panel because between 2-4 years he had 4 febrile generalized seizures, but we did the panel because the EEG was positive. He had some abnormalities, especially during sleep. And he had just mild expressive phonological difficulties, mild coordination disorder, 2 periods of language regression and stuttering after fever. The neurological examination was normal, just subtle orolingual dyskinesia. And here we found a de novo pathogenic variants, stop variant actually, but the phenotype was so mild that we want to study more this patient. And here you can see this, there is a poster with the collaboration of Dr. Martinelli. Here the protein is, there is no expression of protein and there is an mRNA decay. So to see that haploinsufficient patients have a very mild phenotype here, and I think that this is a case that helps a lot in understanding the pathophysiology of this condition. Okay. Other typical sign, red flags. So this is an ADCY5 patient, and we are going to see in a moment the typical nighttime dyskinesia. There are very few genetic disorders with nocturnal spells. One is the PRRT2, and the other genes associated with nocturnal spells have the gene of the G protein cyclic AMP pathway. Maybe we are going to see this. Okay, these are the typical spell of the ADCY5. And here, what happens in PDA2A. This is something that we have to study more because we don't know if dyskinesia appear in the transition of the sleep phases or if they are awakened by the spells. So it's something that we have to study. We have seen this patient in clinic, 34-year male with history of developmental and epileptic encephalopathy, generalized dystonia with prominent cranial involvement. And at the age of 25, he started with severe paroxysmal exacerbation under fever. And after 2 episodes of dyskinetic status under pneumonia, he started with nocturnal spells. So these spells happened early in the morning, were sporadic, long duration, and nicely responsive to a combination of tetrabenazine and benzodiazepine. And this is the... And we sequenced this patient, and he had a diagnosis of GMB1 encephalopathy, so another gene of the pathway, actually the one that works with the G-alpha protein, so they constitute a complex. Okay, we have talked about triggers. Going to the GNAO1. So for GNAO1, these are the two phenotype registered in OMIM, but we know that the clinical reality is much different. We have early onset epileptic encephalopathy, childhood onset epilepsy with movement disorder, mixed movement disorder without epilepsy, with or without neurodevelopmental disorder. We can have a neurodevelopmental disorder which is stable and appearance of dyskinetic movement disorder later in life, and there are milder phenotype described with focal dystonia. But what we see in the majority of patients is severe central hypotonia with global developmental delay. The movement disorder onset is under the age of 2 in 2/3 of patients, and the age at first motor exacerbation is very variable from 1 to 17 years. And what we have seen from a recent review is that the earlier the onset of the movement disorder, the more severe the exacerbations. This is a recent review we worked in the last year, and what I wanted to really highlight is that is not so well described, I think, in literature, is the bradykinetic, hypokinetic dimension of this condition. There are patients with resting tremor, and there is a global reduction of intentional movement. Another sign that makes me think about the Parkinsonian dimension in children are the ocular movement abnormalities. For example, there are children with oculogyric crisis, there are saccade alteration, and there is downward gaze palsy. This is just to underline again that neurodevelopmental disorder is present in almost all variants. The movement disorder is less frequent than neurodevelopmental disorder, but is, I think, the core feature of this condition. And epilepsy seems to be less frequent than movement disorder, with the specific variant more frequently associated. Going to treatment, we don't have many data about the PDA2A, about the PDA10A. We have more about the ADCY5. We know that also the ADCY5 patients are responsive to tetrabenazine, that there are patients that are responsive to acetazolamide, and there are experiences of treatment of DBS. And it seems that ADCY5 patients are responsive. Also, the nocturnal spells in ADCY5 patients are responsive to DBS. So certainly is an option. For GNAO1, we know the classic meds that have been used over this year are tetrabenazine, the clonidine, the benzodiazepine. If there is prominent dystonia, triacylphenidil. There are patients that seem to be responsive to levodopa, maybe specific variants. So also stimulants can be an option in some patients. But we do know that DBS is an answer for a great number of patients. This is part of the review that we work on in the last year. The important data to underline here is that there are 23 patients published up to now with who underwent DBS implantation, and in all these patients, status dystonicus resolved, and there was no recurrence of status dystonicus after DBS implantation. So definitely this is an option in the most severe cases, and I think that we will talk more during this conference. There are, new ideas of treatment for this condition. I think that Simone Martinelli will talk more about this, but we have seen that the phenotype of the mutated C. elegans, which is characterized by increased egg laying, hyperlocomotion, and uncoordination, is significantly improved by caffeine. And we know that in ADCY5 patients, caffeine is definitely an option. There is this paper, which is a retrospective work which has been published a couple of years ago, where there are 30 ADCY5 patients, and in 87% of them there was a clear response to caffeine. We know that the GPCR are druggable targets, and that caffeine is a strong antagonist of A1 and A2 receptor, and seems to be able to reduce cyclic AMP levels. We know also that the ADCY5 variants generally are gain of function, and they're associated with an increase of C cyclic AMP levels. So this seems to be the mechanism of the efficacy of caffeine in ADCY5. We don't have data, clinical data for GNAO1. We know that there are isolated cases that are using caffeine for dyskinetic attacks, and maybe in the next conference we will have more information. So, coming to my conclusion, postsynaptic disorder affecting the G protein-coupled receptor cyclic AMP pathway represent an emerging group of genetic disorder which present with a distinctive clinical phenotype, which include movement disorder, actually mixed movement disorder, epilepsy, and neurodevelopmental disorder. The movement disorder clinical presentation is highly recognizable and is characterized by paroxysmal dyskinesia, sometimes with life-threatening exacerbation, triggered by multiple types of trigger, and maybe, we know this for the ADCY5, maybe this is true also for some variants of GNAO1, maybe responsive to caffeine. There is a prominent oromandibular involvement, axial hypotonia, and hypobradykinesia. I think that this is the clinical signature of this group of condition. Maybe there is a shared pathophysiology or overlapping pathophysiology among these conditions, and I think that this has relevant implications for the clinical and therapeutic management, but also for research on pathophysiology of basal ganglia and for the design of new therapies targeting a specific pathway in the basal ganglia. And thank you for your attention.
Wonderful, perfect time. So we have 5 minutes for a discussion. Any question? So I start with one question. So you show a group of disorders. We share some biological mechanisms, but the impression is that GNAO1 is the disorder who have the most wide clinical spectrum compared to the other. Is there an explanation at the molecular level for this variability?
I think that this is what we have to understand, that this is the GNAO1 and the GMB1, actually, which are the two genes that works together. I think that one reason is the expression in different areas of the central nervous system, because they are the most ubiquitously expressed of this group of genes. And maybe, I mean, they have, in the downstream signaling, they have effects on multiple types of channels. Maybe there is also an effect on the mTOR pathway. So I think that's why they combine this paroxysmal dimension and the neurodevelopmental dimension more than others.
Thank you.
With the microphone. Is there a speculation related to the fact that there are the events, these kinetic events are occurring during sleep in terms of neurotransmitter, hormonal changes, which are specific for sleep?
Yeah, I think that this is another very hot topic. We know that these genes are highly expressed in the nucleus accumbens, which regulates the transition from awake to sleep And I mean, it's an important structure for sleep regulation. Nucleus accumbens, in nucleus accumbens, there is this interplay between dopamine and adenosine. So I think that this is related to the role of nucleus accumbens and the high expression of this protein there.
Any role for melatonin?
I'm sorry?
Any role for melatonin in this?
We have to try. I don't know. Yeah, I don't know. I think that is related to the cyclic AMP level, but this has to be demonstrated. Yeah.
Okay, so over there.
Sorry, just on the sleep topic, what's the typical treatment or, methods that the parents or the families are trying to control it at the moment, please?
I'm sorry, what?
Just with the sleep. Yes,
Yeah.
because, sorry, I'm new to this area here. My son was only diagnosed last year. So we noticed he has problem having a very settled sleep.
Mm-hmm.
He will be like on and off, wake and back to sleep. What's the practical way of controlling it at the moment? Like, is there any medications or is there any methods that the patients are using at the moment, please?
I think that benzodiazepine can help, but they are not so effective in this patient. For the ADC Wi-Fi, there are patients that take caffeine before going to sleep. I think that for now the option is benzodiazepine for a GNAO1 patient, the long-action benzodiazepine as clonazepam, for example. But we don't know. I mean, we don't know the mechanism of sleep disorder in this condition. So we have to understand this first, and then think to the medication.
Okay, I think there is for a brief last question, otherwise we go on. Okay, so it's a pleasure to introduce.
A short question from the two of us from the Netherlands. What is your experience with caffeine in GNAO1? Do you give it to your patients already?
Not until now I didn't, but I'm planning to do it. Yeah.
Yes, because I know that there are families trying
Yeah.
it, but so I was wondering if there are clinicians here that that help those patient families that prescribe the
I think
caffeine.
that there are a number of clinicians here that are curious to try, because it's a very easy way to treat this kinesia if this works. But the problem for GNAO1, I think, is that the patients are younger than the ADC Wi-Fi. The caffeine is not so good for very young children, so we have to think about the formulation, the most suitable formulation. But yeah, I think it's worth to try on the attack. Yeah. Not all variants, I think, will respond to caffeine. It's not a medicine for all the GNAO1 patients, but we need more research.
Okay, thank you, Serena.
Thank you.
So it's a pleasure to introduce you Dr.